You guys ready? You get started? No? Well, listen, after you had the palm test this morning and then sore subject, and then you had palm with Professor Kaplan, I figure I'd be a breath of fresh air and do something different. Like too soon.
Already spread to you.
Okay, well, I'll get to the heart of the matter and sort of. Anywho. Okay, so let's talk about antibiotics a little bit in terms of cardiology. I guess to start with, were there any questions from the heme section we talked about last? With our anticoagulants and antiplatelets and all that fun stuff? You feels comfortable with that, hopefully? I hope so. Okay. All right, well. And they'll come up again, too, because obviously with cardiovascular stuff, that's mainly where those drugs are working. So that's why we kind of put them close together from that standpoint. Anywho, getting into discussing antibiotics in terms of cardiology, this is kind of one of the big places you're going to see this in dealing with infective endocarditis. And basically is where you're finding kind of the vegetation that ends up forming on the heart valve itself. You kind of see here this kind of big clump of bacteria, and so that makes it pretty difficult to treat because it's kind of hard to really penetrate to get kind of deep down in there and to really get full bacterial eradication. And so that's why you're going to see the treatment is going to be a little different than what you might see for like ENT, where you're basically just taking like oral meds, for say 7 to 14 days or something. This is much more intensive, as we're going to see there. And it's fairly uncommon, but certain patient populations are much more prone to get it than others, as we'll see there. Have you covered this at all yet? No. I always hate that because I see you have a whole lecture on it already.
We had a lecture on endocarditis.
Fantastic. See, I see like 6 people who are like yes, and then everyone else is like, I blocked out that memory. I have no recollection of those events. That's okay. We'll talk briefly about it anyway. So again, people who are going to be more at risk here, if they're older, men tend to be a little bit more at risk. IV drug use is an important one. Why do we think IV drug abusers are more likely to get this? Because they're directly inoculating themselves with these bacteria. And so do you think that like a typical like older guy showing up with endocarditis is going to have like a different group of bacteria causing problems than like an IV drug abuser? 100%. Yeah, you're going to see a little bit different in terms of spectrum of bacteria that could be causing a problem there. We'll talk more about that in a moment here. Dental infections can be another kind of common source of these to pop up. Any kind of structural or valvular heart disease. Why do you think this is important in causing endocarditis or leading up to endocarditis? Anytime you're kind of causing kind of structural problems, it kind of gives a little bit of a better foothold for bacteria to grab onto. You know how like when you're like painting something, sometimes you rough it up with some sandpaper so it grips a little bit better? Kind of the same thing there. By causing some structural problems, you can end up finding the bacteria have a better foothold, and that's how that vegetation starts to form there. Which makes sense as well when you talk about things like prosthetic heart valves or any kind of intravascular devices. They tend to grab onto those as well. Any kind of like foreign material, the bacteria like to grab onto and it'll clump on, and then it'll just kind of continue to propagate. So as you mentioned, you'll normally get this kind of thrombus or some kind of abnormal endothelial surface, as I mentioned, and then you'll get the secondary infection that will come about just from normal bacteria kind of floating around in the bloodstream, right? Normally you keep that pretty clean for the most part, but every once in a while some bacteria kind of slip through the cracks, so to speak. And then you start to have that proliferation and the formation of the vegetation on the endothelial surface there, right? So, they just kind of glom onto each other and kind of has this nice big core of bacteria that's very difficult to penetrate with our drugs, as we'll see here in just a moment. Anyway, so what are the causative bugs here? What do you kind of notice in terms of the spectrum here? What's kind of the most common kind of bugs? A lot of gram-positive, right? So again, just broadly speaking, there's a lot of gram-positive bugs here. So already we can start to think about what kind of drugs you might see being used to cover these. It's a really good like broad-spectrum gram-positive drug. Vancomycin, yeah, we'll use vancomycin potentially, or maybe Clindo will pop up, or did you say something different?
No, I said Vanco. I spelled Vanco.
Oh, is he Vanco? You can't be wrong if you say Vanco, most of the time, right? Everyone, you never know where MRSA may strike, right? It's kind of the Spanish Inquisition, like everyone never expects it, but then there you go, MRSA, boom. Glad you put Vanco on board. 100%, yeah. I see who your sponsors are. Some of the checks in the mail, I guess. But so very frequently, though, it can be very difficult to get accurate cultures on this because how do you get a culture for a patient who has endocarditis? just like crack them open and take a little swab. No, you can't do that. So, although sometimes you actually have to go in and replace the valve, as it turns out, but frequently you just get a blood culture, right? So some of those bacteria will kind of fall off, and they should be present in the blood to hopefully culture out and find that. So, Staph aureus is a big common one. Enterococci, viridin streptococci, very, very common bugs you're going to see here. And then occasionally you may see things like fungal infections, maybe like a more immunocompromised patients. And then you also have kind of this HASEC group of bugs here, which can also be less likely, but can still pop up. And this is important to know what the possible causative organisms are, because that will guide your initial therapy there. And so once you get the initial blood cultures done, and should you do that before you give antibiotics? 100%, yes, you want to do that. So get the cultures first, give antibiotics, and then you're going to go ahead and streamline your therapy based on what grows out of that. So you can start broad with something like vancomycin and then stream down if that's going to be appropriate there. And typically we're going to start off with treatment for MRSA, MSSA, streptococci, and then enterococci as well, right? And then typically we like bactericidal antibiotics. Why do you think that is? Because we want something that's going to kill off those bacteria directly, because we know that we're having a hard time fighting off that vegetation anyway. Our immune system's not doing a great job there, so we want to make sure that we can go ahead and kill off as many of those bacteria as possible just with the drugs themselves, right? So with something like Vanco, would that fit the bill in terms of being bactericidal? Right, because cell wall active agents are going to be really good from that standpoint. And so we'll see a lot of cell wall active drugs being used in these cases here. So as I mentioned, initial choice, great choice here is going to be vancomycin, because you're going to be able to utilize this for the MRSA coverage, and it'll get most of those other gram-positives that we've been talking about already. Now here, if you're thinking about it, do you think I'd want to shoot for a higher or lower trough, right? We talked about trough levels being like you do like 10 to 15 for certain types of infections, 15 to 20. What do you think you'd be shooting for here? Higher, why? Okay, yeah, so you could also figure it out depending on like how sick the patient is, if they're how sick they are presenting. But yeah, because that is a difficult to penetrate little area, like you may shoot for higher levels. Even though you're putting it directly into the blood, which is going right to the heart, you would think lower levels would be appropriate. So if it was a simple bacteremia, you can shoot for lower levels of vancomycin. It's fine, because you're putting it right into the blood where you want it to work, right? Versus something like this where you have this endocarditis, it can be more difficult to penetrate. You want to go ahead and shoot for those higher levels. And again, you're right. The results of this could be I have to go and change out the patient's heart valve, right? I don't have to do that if I don't need to. So shooting for those higher levels would be appropriate in these cases here. And what do you notice about the treatment times? Quite long, right? So most infections, you're thinking 7, 10, 14 days, 6 weeks for this one. So a lot longer, because again, you got to keep killing off all those bacteria down to the central core, try to get rid of that. So if depending on the cultures as they come back, what you can streamline down to. So if it's like a viridins streptococci, or if it's going to be the streptococcus bovis, things like this tend to be very highly penicillin susceptible. So this is one of those cases where penicillin G is going to be the drug of choice for these particular bacteria, assuming they're sensitive to that. And so this is a case here where I can either use very frequent dosing, or I can actually use a continuous infusion of this. So this would be running basically 24 hours a day. What's the benefit of doing that? How long am I above the MIC, presumably? 24 hours a day, right? So again, you're getting that constant kill. And penicillin, is that bactericidal, static? Still bactericidal, right? So again, you're seeing that constant kill of those bacteria. That's why you get such good penetration there. Alternatives, we could use things like ceftriaxone, 2 grams every 24 hours. Now, again, this is another one where you'd be shooting for higher doses typically, just because that penetration is so important there. Or vancomycin potentially, right? So if they had a really good reason to not use a penicillin, vancomycin could still be continued. So maybe streamlining down is not always the best choice depending on the situation, as you'll see there. So this is kind of an interesting point here as well. We can actually shorten up our treatment time by using gentamicin. You said gentamicin, wait a second. What kind of coverage does that have against gram-positives? You would rightly say, well, almost none. I know that from the test I just took, that it has like mostly just gram-negative coverage, right? So what's it going to do if I'm growing out this streptococcus? Synergy, right? So this is a case here where you can find that the cell wall active drug that you're using, of vancomycin or ceftriaxone, will kind of help to loosen up those cell walls and allow the gentamicin to get in there. And how do they work? Protein synthesis inhibition, right? But they're still bactericidal, so again, working together, they get better synergy. And what you see here, you can actually use shorter courses. So say 2 weeks of treatment, say, versus 4 weeks. Very beneficial, right? It's less time your patient's potentially in the hospital. And what are you at risk for when you're in the hospital? Secondary infections, right? So again, whether it's bloodstream infections, whether it's pneumonias, whatever the case may be, you're at risk whenever you're in the hospital. However, why is this not great for patients with renal or otic problems? Yeah, that can be directly nephro or ototoxic, right? So you do want to be cognizant of that and make sure you're watching your levels. Now, as I mentioned, we were, in some cases, you may find that they're still using it every 8 hours. It just depends on what kind of dosing strategy they're shooting for. But sometimes you may have to look for peaks and troughs if you're using the more frequent dosing, or when we're doing just daily dosing. Remember what we were measuring there? Just trough levels, right? And what were we looking for in that case? What kind of values? Well, what kind of numbers were we looking for? I say you don't have to memorize these levels, but in this one's pretty easy because it's undetectable, right? So as long as it's undetectable, it shows the patient is clearing it. There's no problem there, right? If I start to get higher and higher levels, it shows they're not clearing it quite so well. So again, that's why we look at the troughs for gentamicin. Why do we look at troughs for Vanco? Yeah, because it's time dependent, right? So you want to make sure it's above or within the gold trough level to stay above the MIC, right? So two different purposes for looking at trough levels, right? Okay, so other stuff you can find, things like strep pneumo tend to be mostly penicillin sensitive, but you just have to follow your cultures and see what those come back as. Now, if a culture came back and it said that something, say it was like penicillin, it said resistant, but it said ceftriaxone intermediate and Vanco was susceptible, is it okay to go with ceftriaxone? It says intermediate. Generally, no, right? So just kind of a general rule of thumb, if your cultures come back and something's intermediate, you don't want to risk the gamble of it not working or not getting high enough levels. Only go with stuff that's going to be susceptible, okay? So if you see like a little I next to it, that means intermediate. It's probably going to be indeterminate if it's really going to cover it or not, okay? So how I kind of think about that. But enterococci, you can see that they tend to be a little bit more resistant to penicillin. So this is another case where I can use something like gentamicin plus penicillin or ampicillin or Vanco, and you get that better synergy there. So again, that's why we like to go with that. Better bacterial kill, shorter treatment times overall. And then for staph, if it came back and it was MSSA, do you need to continue Vanco? Generally, no, right? If it's MSSA, you don't have to worry about that. So that's where you can get away with using like a nafcillin, or even cefazolin could be used potentially. Cefazolin was what class of antibiotics? First gen cephalosporin, good, yeah, and again, plus minus gentamicin for that synergy. If it's MRSA, then you obviously have your answer, Vanco's a drug of choice, right? What if the patient couldn't take Vanco? What if their renal functions all over the place, they just couldn't even get in the right levels, what could I use as backup? Yeah, linazol would be a pretty good option there as well, right? So that'd be a good thing to use. Could I use daptomycin? Why not? Maybe from a renal standpoint, you may not want to do that, but what was the one indication you can't use Dapto for? Pneumonias, yeah. So you could still potentially use it for bloodstream infection, but yeah, you're right. Renal function would be something you want to watch for. What other level do you want to monitor for with daptomycin? The CK, right? So CPK, you can watch for that. The California Pizza Kitchen, they have it. High levels. It's a pepperoni emergency. I'm just kidding. Yeah, so usually means that muscle breakdown's occurring there. You may need to discontinue because of that. Actually, I said that one time. I was like, what does CPK mean? Someone said California Pizza Kitchen. I said, that's correct. Looking at these Haystack organisms here, they used to be more ampicillin susceptible, but then they ended up producing a lot more beta-lactamases. And so as a result of that, we kind of changed up therapy a little bit. So something like a third-generation cephalosporin is appropriate here. Using a beta-lactamase inhibitor also makes pretty good sense. So using something like a Unison would be fine, or in some cases, Cipro might be appropriate, right? Now, looking at these IV drug users, right? I know this just doesn't happen to be a picture from my last weekend outing, but I'm just kidding. It's my insulin, okay? Usually don't do that IV. No. Right here, what's interesting with the pathogenesis for IV drug abusers is mainly due to the fact that they have a lot of different stuff that's getting injected here. So things like particulate matter. So imagine if they were, say, abusing, say, something like a Percocet, right? So oxycodone, acetaminophen. Now, those tablets, when you crush those up, are they just pure drug? No, there's talc and there's all kinds of other stuff that's in there that can eventually, kind of cause these little deposits to form, sometimes in the lung, sometimes in the heart, and that's where you can see the endocarditis develop from there. Not only that, but they also have skin flora, because again, are these patients potentially using really good aseptic technique? I hope so, but not always, right? And then also the use of saliva as a lubricant sometimes, or to clean things off, right? So again, you have to worry about mouth bugs at that point. So you see a much broader spectrum of different bacteria that would be causing these issues here. And so, and again, that's actually, have you guys ever heard of like safe injection sites or like monitored injection sites? Yeah, it's actually something that's kind of interesting. I don't know if they have any here they've trialed yet. It's kind of tough to do stuff like that in the US, but if you look up some videos of some places in Canada where they've done this, they found really interesting epidemiologic impacts on using these safe injection sites, where basically the drug abusers would bring their own drugs with them. So like not like the clinic was buying it for them, but they would bring their heroin or whatever they use to the site. There were nurses like actually on site, and they would provide them with like clean injection supplies and alcohol wipes and all kinds of stuff. And then they would actually like have these little spaces where they would use the drugs, so that way if they got a bad batch or if they overdosed or something like that, they could respond immediately, right? And so what was really interesting is, one, they saw big decreases in like transmission of hepatitis C, HIV, and other transmittable diseases, and also the overdose death rates actually went down pretty significantly. What was really cool is that on the second floor and third floor, they had places to help them with housing, finding jobs, and all kinds of stuff. And so really kind of an interesting sort of way to try to have safer drug use, maybe not enabling necessarily, but trying to help them get back on their feet and things like that. So just a random aside, but there's something interesting you can check out there. We're in America, though. We say drugs are bad, and so don't do them. And if you do them, then you're a bad person. So now you got endocarditis. But again, common stuff here. Staph aureus is going to be a big one. More than half of the cases there. So obviously, what's going to be your big drug of choice? Vanco still holds, right? So Vanco's still going to be good. I'm just going to point at you whenever any Vanco said. But also think about more gram-negatives here. Fungi can be here. Again, think about these patients. They may be immunocompromised just due to things. If they have HIV or if they have AIDS, they could be immunocompromised from that standpoint. So things like fungus could be more likely, right? So things to think about. There's a frequent failure of antibiotics with patients with prosthetic heart valves, and so very frequently they have to go back in and replace them, which obviously is a big deal because that's a lot of surgery and a lot of recovery time and whatnot. Typically, you're going to find that we have to go even more kind of hardcore in terms of our antibiotic coverage, where we actually are going to use a triple drug regimen, which is not something you commonly see. But in this case here, you use things like nafcillin, oxacillin, right? So you have something covered MSSA. You use cefazolin as a first generation cephalosporin or vancomycin, so one of these three, plus rifampin, which is not a drug we've talked about just yet, we'll in a second, plus gentamicin. By using that triple drug regimen, you get even better synergies, right? So we're going to see something that works on the cell wall, we're going to see something that works on protein synthesis, and we'll see what rifampin does in just a moment. But if they do culture out MRSA, it may require surgery in a lot of cases, so just something to note there. So what is rifampin? What do you know about the color of rifampin? Bright red. So if you ever see like it looks like a bag of wine or something hanging on a patient, it's probably something like a rifampin. There's a few chemo drugs that look like that too. But basically, these are going to be really good for helping to kill staphylococci that adhere to foreign materials. So it's kind of a unique property of rifampin. You'll see this used in a few other cases. That you might have mentioned it in pulmonology. Maybe. What disease state was this used to treat? TB, right? So rifampin's the kind of the cornerstone. I'm so sorry if I'm triggering some. Yeah, too soon. But sometimes it's good to bring up repressed memories, and we can talk through it together, and shared trauma and all that. Yeah, so frequently you'll see this used for TB, but also this is good for endocarditis, as it turns out. But resistance is a bit of an issue here. So this is actually a case where you want to start the other two drugs first. So you can start like Vanco, gentamicin first, and then you add on rifampin last. And that actually helps to prevent more resistance from developing to the rifampin, right? My batteries might be going out. Let me know if it goes out. So this one's going to be working specifically by inhibiting RNA polymerase. So it's kind of a new novel mechanism we haven't really seen before. So by doing that, obviously you're preventing things like gene transcription. You're preventing things like proteins from being produced. So nice from that standpoint. As I mentioned, TB being the other main indication. So what's interesting though is that you're going to get discoloration of the urine, the feces, the sweat, and that's mainly just due to the color of the drug itself. So if you had someone who's having, and it's kind of interesting because you may have like patients who are, in the ICU, they're ventilated, you notice these kind of like little orange like drips coming down the side of their face, and that's usually from just tearing being stained by the rifampin. Or if you look at their Foley bag, you notice this kind of orangish discoloration. Normally, if you think orange, red discoloration of the urine, what are you thinking? Think blood, right? In this case here, it's actually the drug itself, right? Whenever I mention medications that change the color of the urine or the feces, I always make special note of that, mainly because I had a traumatic moment when I was a young child where I received some kind of medication. I don't know what it was. My parents can't tell me, but I had bright orange urine, and I was very scared at that time. And I think I finished peeing, and I started screaming for my mom to come help, and I was just like, what's wrong with me? And she's like, oh, it's just a medication. I was like, well, that would have been good to know anytime before. And that was right before my 30th birthday. I'm just kidding. I was probably 6 or 7 or something. Like, it was. Point being, though, is that things change colors like you want to know about, right? So, for instance, like if something changes the color of your feces black, you probably want to know about that, right? When you think black feces, what do you think? GI bleed, right? If you had upper GI bleed causing black tarry stools, you think about that sort of thing. Like, patients hear about this too, and so you want to make sure you note that. So this one will cause a red-orange discoloration. I actually had one really cool case, and I'll probably mention this again at some point, but I had a patient who had overdosed on the drug Azo. I'm familiar with Azo, what you use that for? It's a urinary anesthetic, so it's good for patients like UTIs, a lot of bladder discomfort. You can use that as an anesthetic. Anyone know what color it turns your urine? Turns out orange, right? What was interesting is that when you overdose on that, potentially, it actually is a strong oxidizer of the iron in your hemoglobin, and so it induces something called methemoglobinemia. You know what that changes, what color that turns your patient? Turns them blue, actually. So instead of your hemoglobin having kind of a red color, it looks like very dark bluish. So it looks like your patient's like cyanotic, even though they're breathing just fine. And it's because of that methemoglobinemia. So what's interesting is I had this blue patient who had orange urine from the Azo, right? So I could see like her Foley bag, she had a Foley place and the orange urine was coming out. Well, the treatment for methemoglobinemia is you give the blue drug to a blue patient to turn them pink again. So we have this dye called methylene blue. And so it's a very, very, very dark blue sort of color, but it helps to reset that hemoglobin, the iron, back into the normal state, and then it pinks up the patient essentially. And so gave that to them, and then all of a sudden, what do you think happened to the urine? Well, the orange mixed with the blue turned purple. I don't know. I can't make this stuff up, right? So anyway, think about red and blue together kind of make purple, right? And go back to your primary colors. But it came out purple. I thought that was so cool because all of a sudden we gave the drug and then 5 minutes later you see the urine come out looking purple. And I was like, wow, medicine in action. But anyway. Also, whenever you're changing the color of things, you can also see that some of your lab tests are based on colorimetrics, right? So the actual color of things. And so because of this, you can have things like your LFTs look like they're raised because this is affecting that. Rash is obviously something you can see the patient will have this kind of red discoloration, and that's related to the medication itself. Okay, so, oh yes, ma'am.
Does it affect oral contraceptives still?
Rifampin, yes. This can, okay, so actually I don't even know why I don't mention it on the last slide. So this is a notable mechanism here, and I don't know if I mentioned it anywhere else. Does not look like it. So one thing to note with rifampin is it is a strong CYP3A4 inducer. So this is kind of one of the first cases here where we've actually mentioned a CYP3A4 inducer being in play. So what does this do to the level of medications that get metabolized by the drug? Or metabolized by that enzyme? Yeah, more metabolism means the drug levels are going to go down, right? So it could see therapeutic failure of certain things. Estrogens are a common medication that go through and get metabolized through the liver. I think we kind of mentioned that with that enterohepatic recycling and whatnot. Well, what happens if you induce the metabolism of the estrogens, levels of that can drop down, and guess what can happen? You can ovulate, and then you can potentially get pregnant, right? So one thing to note with that, it's one of the most severe side effects I could possibly imagine, right? Some side effects only last a little bit of time. Some side effects last at least 18 years. 30 in some cases, it just depends.
What other antibiotics just like the amoxicillin, or was there?
No, so really anything that's disrupting the gut flora can potentially interact. And so again, it's a different mechanism there where you're inhibiting the recycling of the estrogen as being the problem there versus rifampin specifically is enhancing the metabolism of it and actually shortening up the half-life of the drug itself. Right, so it's mainly the estrogen effect that you're looking at there. Okay. With me on that. Thank you for bringing that up. That was a definite oversight on my part here. Anywho, so in terms of prophylaxis, so patients may be at big risk for developing endocarditis, and so those patients who, for instance, have like a prosthetic heart valve may be at bigger risk. If they've had a history of infective endocarditis, they're more likely to have it develop again, things like that. And so we'll actually give them prophylaxis in cases where we think that they could be introducing bacteria into the bloodstream, and we want to prevent that from occurring. So just like we would give surgical prophylaxis for someone who's about to go and have, say, their gallbladder taken out, we do the same thing for these patients who are really high risk here. And so what we can do, actually the more relevant procedures here are going to be things like dental work. So like a routine cleaning is probably not going to be a big risk here, but if you're having like a root canal done, or if you're having teeth removed or things like that, there's a risk of having the mouth bacteria getting introduced into the bloodstream, so you'd want to prophylax for that. If you're having, say, for instance, a tonsillectomy or bronchoscopy or something that could introduce bacteria there, or any kind of like skin or musculoskeletal tissue, most times you're going to get prophylaxis for that regardless. So normally we'd have them take it within 30 or 60 minutes before the procedure, and normally amoxicillin is going to be pretty good for that. So if you ever, for instance, see a patient who has like a one-time dose of amoxicillin, I would sometimes see that when I was like, if I was on like a community rotation, I was like at a Walgreens or Publix or something, and I had a patient come in for like a one-time dose of amoxicillin. I was always like, why just one dose? And it was because they had a history of endocarditis and they're getting a dental procedure done. So that's a fairly common scenario you'd run into. As an alternative, though, they couldn't get amoxicillin. Obviously, things like cephalexin, clindamycin, or azithro could all be used potentially, right? Probably cephalexin probably being the most easy, common one to go with in a lot of cases. Okay, so any questions so far? I'm going to go change out my battery and give you guys a 10-minute break, and we'll come back and start talking about our lipids. Let's talk about our lipids. So we have two primary sources of dietary fats, right? So we're going to see that we'll have dietary fat and cholesterol here coming in from the intestine. Another source where we get a lot of our fats from, obviously, is coming from the adipose tissue here, right? And we're going to see kind of how the balance goes between these two. We're going to see how the lipids come into the system through our food, how it turns into eventually into cholesterol, and how that's going to have an impact on our cardiovascular system. Typically, you're going to find the American diet, which changes all the time, but you're going to see that we see some amount of triglycerides coming in, and then also cholesterol. And you're going to find that both of these get basically formed in what we call chylomicrons, which will be abbreviated CM here. In terms of how we digest down these fats while they're actually in the GI tract still, what enzymes are helpful with that? Yeah, lipase is going to be a big one, which is coming from where? The pancreas, right? The pancreas is going to be secreting amylase and lipase and protease and all that stuff to digest the actual food itself. And then eventually we're going to have things like the bile salts and things are also helpful for trying to emulsify those fats into smaller particles so that way they can get incorporated into those chylomicrons, right? So eventually you're going to find that both the dietary cholesterol, again, you're going to be like, why is he making so much of a point to talk about all these things? But this is where all the different medications are going to be coming into play, as we'll see here, because we have quite a few different meds that are going to be good for treating hyperlipidemia and helping to reduce risk for cardiovascular disease. But basically, we start off with the dietary cholesterol, and we also have the biliary cholesterol, right? Those are those bile salts coming out from the gallbladder. They're going to be helping to emulsify and breaking down this cholesterol into smaller and smaller pieces until basically you have the chylomicrons. And then at that point, they're going to be small enough they can actually go through some of these cholesterol transporters in the actual intestine itself, and then they get incorporated into those cholesterol esters, and that's where you see finally that formation of the chylomicron. Where's the first place stuff goes to typically when it gets absorbed from the GI tract? The liver, yeah. So liver is going to be the first big stop here. Just like for medications, a lot of our food particles are going to do the same thing, and so that's going to be important because you're finding that the liver is going to be the primary spot where most of our cholesterol and triglycerides and all that kind of stuff gets processed. Okay. So as I mentioned, dietary fats get carried into the chylomicron. They get secreted from those intestinal cells once that absorption actually occurs. And then what you're going to find is that you have triglycerides in the core of that chylomicron. And what you're seeing here, these little globes, is going to be showing the disposition, or basically the concentrations of cholesterol esters versus the triglycerides. So you're going to see here early on that for the most part, these molecules of the chylomicrons are mainly made up of the triglycerides. Okay, and you'll see how those proportions are going to change as time goes on as they kind of process through here. Anywho, what you find is that the chylomicron gets end up getting hydrolyzed by this lipoprotein lipase, it's LPL, and that's going to eventually turn into these chylomicron remnants, and then basically you have like free fatty acids and you have glycerols, right? Because triglycerides, basically fatty acids attached onto what? Glycerol, right? So that's how you get your fatty acids. Free from there, that's how you get your glycerol, which some of those can be recycled. Basically, these remnants then get removed by the liver. So the liver will have on the hepatocytes these receptors that are available to interact with these molecules and then intake them into hepatocytes themselves, right? So you have this LDL-like receptor protein. LDL just stands for what? and low density lipoprotein. That's what we're eventually going to be making. But right now we're just trying to intake some of those early kind of molecules here in order to incorporate them into the liver, so that way we can form our things like our triglycerides and VLDLs and all that kind of stuff there. Okay. As you mentioned, the cholesterol in that remnant is useful because in the liver it's helpful to go on and make things like the phospholipid bilayer for cell membranes. It's useful for helping with hormone synthesis and things like that. And then it eventually can be disposed of in the bile itself as bile acids, right? Then it can help to break down further fat molecules and to help it be absorbed. So it's kind of that enterohepatic recycling we talked about before. This is where a lot of this happens as well, right? A lot of the bile salts get excreted through the biliary tract, get reabsorbed as time goes on. Okay, so anyway, so the carbohydrates and the fatty acids eventually get converted into triglycerides within the liver itself. Okay, triglycerides then get kind of incorporated in these low density lipoproteins. I'm sorry, they are very low density lipoproteins. These are the VLDLs, but they're very high in triglycerides. So frequently when you get a lipid panel back on a patient and you get a triglyceride count, that's actually kind of a sort of a surrogate marker for your VLDL concentrations. I won't say so specifically, but I'll talk about how you get that calculation just a little bit later. The VLDLs get secreted from the liver itself, and you can kind of see here the VLDLs coming out. There's still pretty high content of triglycerides here, relatively small amount of the cholesterol esters. And also when you look at them, and I'll show you a picture in a second, they have these lipoproteins that are on the surface of them. So that way when they interact with different cell membranes, they'll be able to interact, and if they need to get uptaken, they'll do that. If they need to do other things, that can happen as well. Eventually though, as lipoprotein lipase continues to break down those triglycerides, it's going to turn into one of these intermediate density lipoproteins, the IDLs, and this will be kind of an intermediate step before we get to our LDLs. So then that eventually gets removed through further activity here, and you're going to find that now you have the low density lipoprotein. Once it gets further hydrolyzed there, and now you have your LDLs. And why do we care about LDLs in terms of cardiovascular disease? That's where it causes a lot of that atherosclerosis. That's where you're going to see a lot of inflammation can happen as these gets deposited into, plaques along the arteries and things like that. And so we know these are kind of a big cause for a lot of the oxidative damage and atherosclerosis that we see with cardiovascular disease. Now this is important here. The LDL gets removed by, guess what? The LDL receptor, right? So this is important because some people may have more or less expression of these receptors here, and that can have an impact on basically what their actual resting level of LDL is in the blood at any given time. Because you'll find that, while diet certainly has an impact on it, obviously, genetics plays a really big role too in determining, some people, even though they eat really healthy, they can still have a relatively high LDL count just based off of the type of receptors they express and other factors there. But you're going to find the LDL either gets uptaken into the cells. You may find that it can be further oxidized here through the macrophages, and then eventually we're going to be able. And the liver is another big place we're also going to see these being taken up as well, and we'll see what purposes that's going to be used for. So things to note here. So basically, as you kind of go from the chylomicrons down until eventually getting to the HDLs, you're going to find that the triglyceride content is getting more and more hydrolyzed out. You're going to see eventually, when you get to the LDL content, it's almost negligible at that point. And you can see here kind of where it's going to be synthesized. So VLDLs are mainly your triglycerides you're measuring on a lipid panel. They're going to be mainly happening in the liver here, and eventually they're by further metabolism of those VLDLs is where you're going to be producing your other products, as you'll see. And then this is really important here. I want to note as far as mechanism of catabolism, or how we actually get rid of it, this is really important in terms of LDL and how we get rid of that, as this ApoB100 mediated uptake. So depending on your expression of the ApoB100 protein, depending on how many LDL receptors you have available on the liver to uptake that, is going to be influencing how fast you're getting rid of that and clearing it from the blood. Okay. And looking at a chylomicron, apolipoprotein, basically you can see here all your triglycerides and cholesterol esters kind of in the center here, whereas you're going to find cholesterols make up the the kind of outer membrane here, and here are your proteins you're going to be interacting with the cell membrane. So if it needs to, say, for instance, take up some VLDL in order to form some new cell membrane, it can do that. If it needs to get uptaken by the liver, that's also where these receptors are coming into play here. Okay, so as I mentioned, with LDL particles, they're coming out from the catabolism of those IDL particles, and you see the half-life here is about 1.5 to 2 days or so, depending on the patient. And as I mentioned, with the ApoB100 protein, that's going to be the thing that actually binds LDL to its receptor. So when you have like an LDL receptor sitting there in the hepatocyte, it's an ApoB100 protein that's actually binding to the signal that needs to be uptaken into the cell itself. As you're going to find, these receptors are super important because as you find that they're responsible for about 75% of LDL particles and getting rid of those, okay? And so as you find, anything we can do to try to increase the number of LDL receptors available in the hepatocytes is going to help to get rid of that LDL. So more LDL receptors means less LDL in the blood. Okay, so that's a big takeaway there. A lot of our medications are going to try to either directly or indirectly influence that to try to make sure that we can help and increase the number of LDL receptors as much as possible. Okay, when you have low receptor expression, you're going to find you have more accumulation of LDL particles out in the blood. They can then get into the vascular endothelium, cause those nice atherosclerotic plaques that cause inflammation, all kinds of bad stuff over time. And so this is what we're trying to interrupt with this here, because we know that when we give things that lower LDL concentrations in the blood, what happens to cardiovascular mortality? It decreases, right? Because you get rid of those LDLs, you see less plaque formation, you see less likely for them to develop heart attacks and things like that. So we know it works. Here's an example of how the actual receptor action works. So imagine this is a hepatocyte here. Imagine this is going to be the LDL receptors being put up into the cell surface. It's going to interact with the ApoB100 protein here. And again, this is the LDL particle itself. This is going to, when it binds, it says, okay, let's go ahead and take this in. What's this process here where it actually kind of engulfs it and brings it in? Yeah, endocytosis, right? All those little things you think from undergrad biology, they'll never come back every once in a while. So again, this interaction is really important because otherwise it doesn't know it needs to take up or uptake that LDL particle here. So it's going to undergo endocytosis. The lysosome is then going to start to break it down to where it can then use things like any amino acids that are there, any cholesterol esters, triglycerides, whatever it needs from that particle. It'll then start to break it down, and then it should recycle that receptor back up here to the cell surface. Okay. Some ways we can interact with that, right? So if the cell itself has enough cholesterol in it, and it's like, I don't really need any more LDL, what do you think happens to the expression of those receptors? It decreases, right? Because the cell's like, I got enough, I don't really need any more. Then it will decrease the expression of those receptors there. What would happen if I did something internally to the cell here to say like, oh, it actually needs a lot more cholesterol. It needs, I'm decreasing the amount of, say, triglycerides it has available to it. I'm doing something that interrupts that process. What happens to the expression of the receptors then? It's going to go up, right? Because it says, well, I need to get cholesterol from somewhere. I need to get my needs met as a cell. So it's going to increase the number of receptors at the surface, and that'll then uptake more of the LDL, right? And the primary place we're going to be doing this is the hepatocytes. We can try to uptake that, and you'll see that process happen when we're giving our medications. Okay, so enough of that. It was a lot of boring pathophys kind of stuff here, but looking at the actual, I guess just the phys aspects of it, but let's look at the drugs we're going to use to actually treat hyperlipidemia itself. So we're going to find a couple different ways that we can do this, right? So there's going to be what we call the statins. I'm sure everyone's heard of the statins before, right? Talk about that. We'll talk about things that help to actually block the absorption of cholesterol from the actual GI tract itself. We'll talk about things that can help to prevent, say, the reuptake of things like bile acids. There's a lot of different ways we can attack this problem in order to help increase the uptake of LDL from the blood itself, okay? And again, presumably the things we're trying to shoot for when we're treating hyperlipidemia is to try to get our triglyceride content down, LDL content down, and which particle do we want high numbers of? HDL, right? It's the good cholesterol, so to speak. And so that's going to be something that some of our drugs have better impact on. So that's the thing you're going to notice here as well. Some of the charts we look at, some drugs are really good for LDL, some are really good for triglycerides, some are really good for HDL bumping, all kinds of different things there. We'll see how those interact. Okay, so this is the different classes of drugs we're going to talk about here. We're going to have our HMG-CoA reductase inhibitors. Now again, the actual process that this is interrupting is very long and complicated. I'm not going to get super in-depth, but just know that HMG-CoA reductase is the enzyme that the statins are inhibiting. That's all you need to know about that class for the most part. We'll get more into detail on those. But how can you tell a drug is a statin? Because it has statin in the name, right? So like there's an island even that's really good for cholesterol. Staten Island, right? No. Took a little bit of time there. We'll look at some cholesterol absorption inhibitors. We'll look at some of our fibrates, bile acid sequestrants, and then nicotinic acid. And now we actually have the newest class. This is called the PCSK9 inhibitors. And this is actually another group of monoclonal antibodies that we're going to be running into here. So those of you guys remember that from the last time we talked about them. These are going to kind of rear their monoclonal heads again. Anywho, so let's talk about the statins first, getting into that. So we mentioned we have quite a few of these available. When these first came out, it was kind of one of those blockbuster kind of things. We're like, wow, these are really having really good effects. Every company wanted in on it, and so that's why we ended up having a lot of these out on the market. And so you're going to find that while they all are having the same mechanism, not all of them are really created equally. We'll see that some are better, some are more potent than others, and also going to see there's some significant drug interactions you have to worry about as well. So things like lovastatin, simvastatin, pravastatin, fluvastatin, atorvastatin, rosuvastatin, and pitavastatin, right? Fairly straightforward in terms of the naming convention. If you see a statin on a test, you automatically know what it is, right? So how do these drugs work? Okay, so looking here, we're going to see we have our hepatocyte here in the green cell, and here we're going to see our systemic circulation. So basically what we're doing here is that by interrupting the process of synthesizing cholesterol within the hepatocyte, so again, you're getting all those triglycerides and things like that from triglyceride fatty acids, glycerol coming in from the chylomicrons. You can't actually synthesize the cholesterol itself because we're inhibiting that process with the statins, okay? What this does is it will lower the intracellular cholesterol content, and what do we say that does to the expression of the receptors? It's going to increase it, right? Because it says, well, I don't have enough cholesterol. I need to get it from somewhere, and I know that we have this reserve sitting there in the blood called LDL. So it's going to then increase the receptor synthesis, which is going to increase the expression here on the cell surface, and so you're going to find that you have more uptake of things like LDL. You're going to have more uptake of things like your VLDLs and things like that because it's trying to process more of those because it needs to get that cholesterol in there. Because again, what are we using cholesterol for? Hormones, cell membranes, all kinds of different things. We need that cholesterol for our purposes, but if the hepatocyte can't make it, it's going to take it up from those extra reserves in the bloodstream. So basically, you're going to see less VLDL being made here. You're going to see less LDL. You may see some bumps in HDL a little bit, but that's not really going to be the main hallmark of the statin action, as we're going to see here. So other things. So you guys ever heard of the term pleiotropic? It's another fancy term you can use to wow all of your friends at your parties, your fancy parties that you go to. You can say, well, in addition to this aged cheese having quite a bit of tyramine in it, which could interact with linazolid, you can also say that it may affect your cholesterol, and in which case you might want the pleiotropic effects of a statin. Basically what that means is these are kind of additional benefits. These are kind of like the fringe benefits of the drugs that aren't really directly related to its mechanism of action. These are things that we've noticed in clinical trials when we've used statins, the additional benefits we get out of the drugs that really doesn't have any direct effect from the fact that we're lowering that cholesterol level here. So what are some things that it does? Well, it can help with things like endothelial function. Maybe it was not the batteries. Maybe it's something else going on here. I wasted 2 good batteries. Darn. It helps to stabilize atherosclerotic plaques, right? So any plaques that are there, they're less likely to break off and form a thrombus. You're going to find that it has some inhibitory effects on things like the vascular smooth muscle, right? So less smooth muscle growing around the vessels, the more kind of pliant it can be, which can help with blood pressure, things like that. Some platelet inhibition, some reduced leukocyte adhesions, all these different things here help with blood pressure effects and help with ischemia, reperfusion injury after a heart attack. They can help with all these different things here. And again, it's not related to the direct mechanism of the drug. We just know that these are things we see when people are taking statins. So as a result of that, you're going to find that statins are really the gold standard main drug of choice for patients with hyperlipidemia or those that are at risk for cardiovascular disease. And that's one thing we're really seeing away from or changing in the guidelines as of recent is that before we only shot for certain numbers in terms of getting LDL down to a certain level or getting HDL up to a certain level. Nowadays, we're actually looking more at what is the risk of having a cardiovascular outcome in the future and how can we try to minimize that with the use of statins. Not to say that any of the other drugs are not being used as well. However, this is going to be a case where we can, use other drugs for their kind of unique places in therapy, but for the most part, most patients end up on a statin. So looking at this, you don't need to memorize all the facts off of here, but a few things I want to make note of. One thing, obviously, and what do you think I'm going to go to first? Which one? The metabolism, the enzyme pathway? Yeah, that's probably one of the I want to go for because it's probably the most important thing on this chart here, right? You can shake your head, yes, I'm saying that. So it's probably going to be one of the big things here. So what do you notice about some of the enzyme interactions here? Or the enzymes that metabolize these drugs? There's a lot of CYP3A4, right? There's a lot of CYP3A4 interactions, or just CYP interactions in general you can run into here. And so that's really important because, like I mentioned, you can run into issues of grapefruit juice inhibiting CYP3A4. You can run into a lot of other drugs. If I put my patient on azithromycin or something, that can have an interaction. So these are things you have to consider when you're adding on, new medications to someone who's maybe being on one of these statins here for, years potentially, right? You may not think about these meds because they've been on it for so long. You got to think about it though. And so you're going to see certain drugs may be beneficial because they don't have a risk for those interactions here. So things like, say pravastatin, enzymatic and nothing specific to the CYP enzyme system, so there's no interactions from that standpoint. Rosuvastatin, really good because it has very minimal CYP interactions here. So these are things that we like to look for. Now, it doesn't mean you can't use the other drugs. It just means you have to be a little bit more careful in combining different medications together. One thing to note with that. Also, you can see here that for the most part, even though some of these drugs may not have the longest half-life, most of them are still dosed one time daily, which is very nice from a compliance standpoint. And you may actually see these used in combination with other drugs, potentially other anti-lipemic agents as a combo drug there. Most of these are not going to have a whole lot of renal elimination, so you don't have to worry about that so much, but certainly you have to consider the hepatic elimination. Patients with poor liver function probably going to have a little bit harder time clearing these medications, as you'll see there. Okay. Food may have kind of a variable effect. This is not something I think about a ton, but certain drugs may really help to enhance the bioavailability of the drug. So these are things you may want to consider on a case-by-case basis there. But okay, so looking at baseline sort of effects here, not only are the statins going to have good effects in helping to uptake more LDL out of the bloodstream, but it also helps decrease the amount of VLDL you're actually producing in the first place because you're interrupting that whole process there. And so here's a case where by using the statins, you lower your triglycerides as well. And what's interesting actually is that the higher triglyceride count is at baseline, the better these drugs work to help reduce them. So as an example here, looking at the actual effects in terms of the percentage change, you're going to see here with things like, simvastatin, when the baseline triglyceride is less than 150, is that like a good number, bad number? It's fine. Yeah, it's totally fine to be less than 150. It doesn't really have much effect. It might actually increase it ever so slightly, which is interesting. But more often than not, you're going to have patients with high triglyceride content. Remember, this is evidenced by this is basically a surrogate of the VLDL content in the blood, right? And so what you find is that you can see that the higher it goes, the better these drugs are working to actually reduce those concentrations there. So very good from that standpoint. If you need to get LDL down and triglycerides down, this is going to do both of those for you. Now, what are some common side effects you're going to find with the statins? Certainly, you're going to see things like GI intolerance, you see a little bit of fatigue and whatnot, but for the most part, people tolerate them pretty well here. Other things to note, you may have some flu-like symptoms in some patients. One thing I do want you to know, though, these can be liver toxic, so you do have to watch for that. Relatively low number of patients are going to develop this, but this does increase in a dose-dependent manner. What does that mean? The higher the dose, the more likely you are to see side effects, right? The more likely you are to see these LFTs start to bump up here. Again, it's rare that you'd have really serious liver injury here, but this is those problems you run into where you're trying to shoot for a high dose of a statin. You may be having a metabolic interaction where you decrease metabolism, and all of a sudden that's where those injuries really come into play here. So what can we do if you have a patient, say you're monitoring them, you start them on a statin, so they come back 6 weeks later, you notice their LFTs are starting to bump, right? So you're looking at AST, ALT, what's a normal value for those? Excuse me. I usually think like less than 30 is usually fine, right? It's usually, because again, like your LFTs, those are the liver enzymes. Where should they presumably be residing? In the liver, right? So if I'm measuring them in the blood, it shows there's a problem, they're spilling out, right? So as long as they're less than 30, usually no big deal. But if it comes back and say it's gotten, they're up in the hundreds, the triple digits, right? That's evidence that something's going on. These cells are releasing their contents. I probably should be somewhat worried about that. And so this is a big reason why we can either reduce the dose of the statin, or if in cases where it's more severe than that, then discontinuing altogether may be reasonable. The other big thing you can find, especially this is big with a lot of drug interactions where you're bumping up the levels of the drugs due to decreased metabolism potentially, are going to be things like myalgias and myopathies that can develop here, and very rarely you can end up having things like rhabdomyolysis, okay, which is what? It's really severe muscle breakdown, right? And this is due to the drug specifically. And so what you find is that patients who have, say, poor renal function, who have a harder time clearing things like myoglobin through the kidneys, you have to be using these pretty cautiously. So we want to be at least aware of that. And then using the lowest effective dose can help to minimize this. However, you're going to find it's kind of directly incompatible with the guidelines, which are saying, for certain risk categories, like we're going to shoot for high intensity statins, which means we're shooting not necessarily for a number of your cholesterol, but what's the highest dose of statin we can get to get kind of the most intense effect out of these patients. And I'll show you those guidelines a little bit later on. But again, be careful with any other drug interactions. Like if you mix a statin with a fibrate, which we'll talk about later, if you mix them with something that inhibits a CYP enzyme that metabolizes the drug, you can really run into some big problems there. So you got to be cautious and make sure to let patients know what to look out for, right? So again, if they're, say, couch potato and they call you up and they say, man, it just feels like I ran a marathon yesterday and I didn't really do much, that's usually indicative of something not right? Or what does their urine look like? Yeah, kind of tea-colored. I don't know if you guys ever go on certain websites where it's like certain fitness websites where usually around New Year's you'll have someone who will post on there and be like, hey, I started this new regimen. I'm working out 12 hours a day, 7 days a week, and all of a sudden my urine looks like this, and they show a picture and it looks like Coke basically. And everyone's like, you just need to go to the hospital. And then they're like, nah, I'm good. I don't have insurance. I'm just going to drink a bunch of water. And you're like, oh no, you need to go to and sure enough, they eventually come back from the hospital like, yeah, I had kidney failure, and yeah, it's not great. So those are things we want to be really cautious of and let them know, like these myalgias, they may be indicative of a big problem, may need to decrease the dose, maybe just DC altogether, right? But it's usually as a result of the drug interactions, okay? Anywho, so some other problems, I'm completely off. Get frustrating. But, so again, be careful in terms of hepatic disease. This is going to be contraindicated completely in pregnant patients. You cannot use statins in pregnant patients. Why do you think that would be a problem? You need cholesterol. You need, imagine if you're a fetus and you're like, I'm making a lot of new cells here. I need a lot of cell membranes. I need a lot of hormones, and all of a sudden I can't produce that. No bueno, right? So this is why these are going to be contraindicated. There's one class of drugs we'll talk about later on that is indicated for pregnancy if you really need to treat their hyperlipidemia, but for the most part, this is something we want to avoid if we can. So this would be one of those category X kind of drugs where, again, there's no reasonable use for it. The risks always outweigh the potential benefits, okay? Anyway, relative contraindications, you got to be careful if you're combining with other medications, anything that can increase levels of these drugs like erythromycin, other anti-lipemic agents we'll talk about later on, things like gemfibrozil, niacin. Look out for your interactions. Anytime you're adding something onto one of these regimens, just do a quick interaction check using LexiComp, whatever you're using, Hippocrates, and you can look to see these interactions. They'll come up as big blinky like category D interaction, category X. You gotta be careful with those. Okay, so as I mentioned, the drug interactions mainly are coming about from the CYP450 mediated ones. Remember, there's a few that we saw that help to get around that in a lot of cases. So things like pravastatin and rosuvastatin were nice because they didn't really undergo much CYP interactions because they just aren't metabolized by those particular enzymes there, which is nice. However, there's a lot of drugs that will help to inhibit things like CYP3A4. We'll talk about some of these drugs later on, things like verapamil, amiodarone, and then a lot of your other anti-lipemic agents, things like niacin and fibric acid derivatives. We'll get into these in this lecture set. Will also inhibit the metabolism of the statin, so you got to be careful mixing those two together. And then I mentioned grapefruit juice. Not only is it inhibiting CYP3A4, but what else does it inhibit? There's a certain transporter that it inhibited. It's 3 letters. Or PGP, or P-glycoprotein. It's one of those efflux pumps. You have a lot of those efflux pumps in the GI tract, and so if you inhibit that, normally it would be sending simvastatin back out of the GI tract, or back into the GI tract. If you inhibit that, you increase the bioavailability of the drug, and that increases the overall body exposure to it, right? So grapefruit juice, think PGP, think CYP3A4 inhibition. It's going to be doing, what does he think it does to the half-life of, say, something like simvastatin? It's going to increase it, right? What do you think it does to the bioavailability? Increases, right? So kind of keep those relationships in mind. You can don't completely throw out all the pharmacodynamic stuff we talked about. It's only a few months ago, I swear. It feels like it was a lifetime ago, but it was only a few months. Anywho, so as I mentioned, statins tend to be the most efficacious. They tend to be the best tolerated out of the bunch here. And so these are going to be first line for almost every single patient you're dealing with cardiovascular risk. For those that have high cholesterol, these are going to be the ones you go with. Okay, so up next, and again, I'll talk about comparing and contrasting the drugs a little bit later on, so we'll kind of come back to that and deciding kind of which statins we like to use best. We'll kind of wrap up towards the end with that. Up next, we have the cholesterol absorption inhibitor. It's going to be Ezetimibe or Zetia. So this, again, this is working from the site of the actual GI tract itself. So basically by preventing the uptake through the intestine, more of it stays out in the GI tract and you don't have to worry about absorbing it in the first place. So not only will it work potentially on dietary cholesterol you're ingesting, but also from the biliary cholesterol you're sending out in the form of bile salts. That also helps prevent that enterohepatic recirculation, which is nice. So by blocking that, you're going to then see that not only this is actually really good to synergize with something like a statin as well, is because not only do you have, like, say, the statin inhibiting the synthesis of cholesterol in the liver, but then also now you have something blocking the intake from the GI tract altogether. So a very powerful combination potentially if maybe one was not working by itself. So as I mentioned, how do you think this affects the LDL receptors on the hepatocytes? It would increase it. Why is that? Yeah, just because you're absorbing less. So just like the statins help to decrease production of cholesterol actually in the cell itself to increase LDL receptor expression, here you're trying to prevent the actual uptake of the cholesterol in the first place. So that way it never makes it to the hepatocyte. Thus it's going to have the same effect to increase this LDL receptor at the cell surface there, right? So this is going to be good to help decrease that intestinal delivery. You're going to have to see more LDL receptors and then less cholesterol content of the actual atherogenic particles like your LDLs. However, we don't get all those nice pleiotropic effects like we saw with the statins, which was why these are not going to be first line as the statins might be, right? And so, again, it's also a nice thing as well because ezetimibe itself is enterohepatically recirculated, so you don't see a ton of systemic side effects because most of it's just kind of staying in that little cycle there. So it's kind of one little benefit of the drug. And so normally ezetimibe either by itself or a lot of times we would see it in combination with the statin. So again, what is the benefit of combining two together? Compliance typically, yeah. So instead of taking 2 pills, you just take 1 pill 1 time a day and it's good to go. So like Vytorin would be an example of mixing the two together. So looking at sort of the effects you might see here, usually ezetimibe just kind of give it 1 fixed dose 1 time daily. You see like a 15 to 20% additional LDL lowering when added to a statin. So you do get some potential really good benefits out of this by adding it on. And again, nice because no worry about administration in terms of food, anything like that you have to really worry about. So most of the adverse effects you're going to see tend to be more GI related, mainly because it's working out there in the GI tract to prevent absorption of the cholesterol. Now, what kind of GI effects might you expect to see? Yeah, maybe like diarrhea could be a big thing there. Now, this is not going to be the same. You guys ever remember that drug called Ally? It went over the counter a couple of years ago. Probably like before the time I was in school, even by a year or two. So that was an actual thing that blocked all fat absorption altogether. And so I'm trying to remember the generic name of it now. It's Olestrin or something like that. Olestra, is that right? I'd have to double check that. Anyway, but the point is that basically blocked all fat reabsorption. And what do you think that did to the stools? Really smelly, really greasy because they had a lot of fat in them, and it would stain your clothes and things like that. So they'd actually recommend like bring an extra pair of brown pants with you everywhere you go. I'm not kidding. They were like, bring dark pants with you, like just in case, because it was just, that was a natural side effect of the drug itself. This is not going to be as bad because this is really just affecting cholesterol specifically and not necessarily all fat that's coming into the actual GI tract. Okay. Also, this can have some additional additional effects on the transaminases if you include this with the statin. So just be aware you may need to adjust the doses of the statin down in order to account for that. Now, you can see issues, especially if you're combining this with some of the other anti-lipemic agents. So as an example here, when you mix it with the fibric acid derivatives, which we'll talk about in a moment, you can actually end up seeing some more of these hepatobiliary sort of side effects, meaning you can end up developing things like cholelithiasis, myopathies potentially. Again, relatively low risk, and there's not a ton of patients you're going to be combining these two with anyway, but just things to kind of think about. Bile acid sequestrants, this is a class we'll talk about in a few minutes as well. This is actually interesting because, as you might imagine, what do you think the bile acid sequestrants do? They sequester bile acids actually in the GI tract, so whatever you're sending out there, the biliary tract would bind it up and then just eliminate it through the feces. This would eliminate that because it would bind up to the ezetimibe too, coming out through the biliary tract and just decrease the concentration. So that may actually decrease the efficacy of the drug itself there, right? Antacids can have a problem here. And then cyclosporin. We mentioned cyclosporin before. Where did we mention that? We mentioned for chronic dry eye. Remember, it's an immunosuppressant. This is going to be more not for patients receiving Restasis for dry eye. This is more for like patients getting cyclosporin as treatment for a transplant. They're trying to prevent graft rejection or something like that. So just know that you can see some alterations of the drug levels depending on the drug interactions. Okay, next we have our fibric acid derivatives. And so we have 3 that fit into this category. We have things like gemfibrozil, we have fenofibrate, and then bezafibrate. We have 3 drugs in this category. And so this mechanism is going to be a little bit different than kind of what we've seen previously. So basically what these do is it activates what we call PPAR alpha. So PPAR alpha here is it's basically a transcription factor affecting the DNA itself, right? So basically what you're going to find here is that, I'm going to find where you find that. So basically what it does is it increases the fatty acid oxidation. So you decrease the amount of triglycerides being sent out through the actual hepatocyte itself, right? So again, you're decreasing the oxidation here, so you're going to find less VLDL actually getting out into the bloodstream. And what does VLDL eventually turn into? LDL, right? So again, you're going to see kind of a downstream effect here, where by affecting the triglyceride metabolism, you're going to be eventually affecting LDL concentrations as well. So you see decrease in triglycerides, and then that also end up increasing expression of this ApoA1 protein, and that's going to increase HDL content. So by looking at this, you can see that it'll have some of an okay effect on LDL, but the big thing it's going to do is to decrease triglycerides and increase HDL, which we know to be protective, right, for cardiovascular disease. So total cholesterol overall may be down by 15% or so, but the majority of that is going to be due to the effect that you have on the triglycerides. And we'll talk about how you can calculate that in just a little bit. But the big thing here, kind of modest effects on LDL, not nearly as much as you would see with the statin, but the big benefits here are bumps in HDL and lowering the triglycerides. Okay. Some people have a genetic predisposition just to produce a lot more triglycerides. This might be an okay drug for them. If you have a patient who maybe is on statins and their LDL looks good, but their HDL is still pretty minimal, you may be able to add this on, maybe increase that level, to where it's a little bit more protective. Just really depends on the situation. Definitely not going to be like a first-line drug by any means, but it could be a useful add-on agent potentially. Gastrointestinal effects are going to be the biggest thing you see here. A lot of abdominal pain, nausea, diarrhea associated with that. You can see some myopathies, which would this synergize with in terms of drug interactions? All right, so you can see that more so with your statin. So adding this onto a statin could increase that risk of myopathies. You may want to either adjust the dose down of one or the other, or just see how the patient responds to it. And then cholelithitis, as we mentioned, could be a risk, especially when you mix it with Ezetimibe. Is a big thing you might want to consider. Again, you do not want to give this in pregnancy. Don't want to give this in any severe renal hepatic disease here. And then if they already have existing gallbladder disease, you definitely don't want to add this on, because that's just going to be more likely to exacerbate that. Because those would be the people you probably want to avoid using the fibrates in altogether. So, as mentioned, the drug interactions here, one thing you can actually find is some increased anticoagulant effects on warfarin. No specific mechanism for that, maybe having to do somewhat with the metabolism of it, but it can increase your bleeding risk on patients with warfarin. It'll certainly lead to increased risk of myopathies and things like that with HMG-CoA reductase inhibitors, which is just another name for our statins. Good. We mentioned cholelithitis with Ezetimibe, and then additional sort of abdominal effects with the bile acid sequestrants, which we'll talk about next year, I think. And so as I mentioned, this is going to be good for patients who either have very high triglycerides, so say something like greater than 1,000. We mentioned less than 150 is usually pretty good, but if they have a familial hypertriglyceridemia, this might be a really good drug for those patients there. Or if they have low HDL you're trying to raise up, that could be another good option for using the fibrates. Okay, so next we have our bile acid sequestrants. These are otherwise known as our resins. Normally resins do what? Bind to things usually, so they kind of hold on to things, and so this is what our resins are going to do here. And essentially what this does is that you'll find that normally what happens is you're kind of following this in a counterclockwise sort of fashion here, is you have your gallbladder releasing out all your bile acids, right? Bile acids are useful because they help to emulsify a lot of our fats that are coming in through the diet, and so then you're going to find that this will prevent the reuptake or the recycling of those bile acids, because they're being bound up by these resins. So where do they get eliminated at? Through the feces, right? They're just going to get eliminated through the feces there. So you block the reabsorption of the bile acids. What does that do to the cholesterol content in the liver? Because I'm blocking reuptake of the bile acids, so cholesterol content goes down, right? Because I'm just intaking less of it. And so what does that do to my expression of the LDL receptors? Goes up. Just like so we saw with the Ezetimibe, how it's blocking at the intestinal level. This is working differently because it's working at the site of the actual bile acids to bind them up physically and prevent them from being reabsorbed. Okay, so slightly different mechanism there, but it's important to make that distinction between the two there. So again, by binding up those bile acids. Your liver says, well, I got to make more bile acids. Where am I going to get the cholesterol from? Well, the LDL is floating around in the blood. That's going to be the best way to get it.
So is there kind of like a double effect going on with a lot of these, where it's like not only is it taking some of it out, but it's also making the liver stronger at taking more, at also metabolizing more?
Essentially, yeah. So if you're decreasing that cholesterol content within the hepatocytes themselves, I mean, they have to still do their job, right? So they say, well, I got to get the resources from somewhere. They're not getting it from the diet or what's coming in from the GI tract, and they got to pull it from the blood, essentially, right? So that's kind of how they're doing that in that case. That make sense?
Yes.
Anyway, so their mechanism that I mentioned, just binding up the bile acids, getting them eliminated through the feces here. So what do you think is going to be the big side effects with these? Be a lot of abdominal discomfort, a lot of bloating and diarrhea potentially. You're going to see a lot of issues with that. The nice thing with this though is they actually don't ever get absorbed from the GI tract. They always stay just in the GI tract, whereas Ezetimibe we saw it did get some limited absorption and was recycled. Here, there's no absorption whatsoever. So who might this be good for? What kind of patients do you want to have limited drug exposure in? Pregnant patients, yeah, absolutely. So pregnant patients are going to be the big place here. Now, again, this also could be good for kids. However, I'll tell you that very frequently, the rare cases where we need to treat kids for hyperlipidemia, there's been some cases I've seen where we've used statins, usually more like in teenagers and things like that. Occasionally, we may use a bile acid sequestrant for these younger kids, just because we don't have a ton of evidence for use of statins and things like that in that young patient population. But this is going to be better for pregnant patients for sure if you needed to absolutely treat that. However, what's a big problem with pregnant patients in terms of their GI tract? They already have plenty of abdominal issues to worry about, including a lot of constipation or diarrhea or vomiting, bloating, things like that. So they're already having a lot of problems. This is just going to exacerbate that. So again, you can be like, well, we can treat your hyperlipidemia for the next 9 months. But you're going to have some significant side effects to go along with that. The three that fit into this category are going to be cholestyramine, cholestyramine, and then cholecalciferol. So these are not great in terms of dosage forms. A lot of them end up coming in powder. So cholestyramine comes as a big powder. Cholestyramine, what do you know about the doses here? Dosed in grams, right? What do we normally dose drugs in? Milligrams. Ezetimibe is like 10 milligrams. Simvastatin is like 40, maybe 80 milligrams. So this is a lot of just drug product itself. And so it comes in these big kind of bulky packets of powder. What do you think it does in terms of compliance? It's not great because, again, you got to mix it into like a glass of juice or water, and they're pretty gritty and they're kind of gross, and like patients don't like to take it very much, which can be an issue in terms of their actual willingness to take it, right? And so you can see here that depending on, and look at me, I made a bad mistake here. What did I do? QD, look at that. Even, let's take away my license. It's actually in my backpack. I just renewed it, but just go shred it now. Point being, though, is that, depending on what kind of effects you're looking for, you're going to find that, you can bump up your dose pretty significantly because there really is less risk of having any systemic effects. Just the bigger your dose, the more often you're pushing it, the more GI effects you're going to end up seeing there. Okay. Yes, sir.
Have you ever seen them written as gram as GM for clarification?
Not frequently. I've seen in some places where it might be expressed as that, but mostly just G is fine for our purposes.
I saw it a lot on the East Coast. I don't know if that's a thing.
Is it East Coast kind of thing?
Yeah.
GM is an East Coast thing. I don't know if that's a thing or not. Anyone else know?
I saw it a lot, but I'm used to grams being expressed. Just wondering if that's.
Yes, I have no idea. Yeah, usually, at least for all drug dosing purposes, I'm used to running into G is the pretty standard nomenclature for grams. So I'd just go ahead and stick with that. GM, people might start thinking about the grandma, and they get kind of sad about it, and then so let's just stay away from that. Yeah. Anyway, so as I mentioned, their powders have to be either mixed in like water or fruit juice, and so because of that, they get really kind of gritty. And so, anyone ever taken like a Metamucil, like a fiber supplement? More if you should think about that. It's really good quality of life kind of thing. But anywho, it's kind of that same gritty sort of texture to it from what it's been described to me as. And so you can sometimes mix it with like something kind of pulpy, like some orange juice or something, and that would actually be good to help kind of cover up some of that texture sort of issue there and mask some of the taste. Now, they mentioned taking it within an hour of a meal. Why do you think that is the case? When are you sending out the most bile acids? when you eat, right? Because that's when you're trying to emulsify all of those fats and whatnot. So that's the case there where we're going to be administering it around mealtime, so that way the drug can be most effective when the gallbladder is actively sending out all those bile acids there. Now the problem though is with these resins is guess what they also like to bind to? Other medications. So you got to separate them out, right? So we either say like maybe take your other medications, say an hour before one of these bile acid sequestrations, or in some cases we'll just say, well, maybe wait 4 hours after, right? So this is something where patient wakes up, they want to take it with their breakfast, maybe take their other meds an hour before their breakfast, take this, then their breakfast, and then they should be good to go. That way you don't have them binding up with one another, okay? That's an important distinction to make. Okay, in terms of adverse effects, so this is really just the biggest thing is most patients will stop taking this because they feel so miserable on it with all the bloating, the flatulence, all that kind of stuff there. So not great. Also, you can actually end up seeing some malabsorption of vitamins A, D, E, and K, which is important because those are the fat-soluble vitamins good, and the folic acid is also going to be inhibited as well. So this is something you want to be concerned with, especially if they have like pre-existing anemia or things like that. It can be problematic. Now, one thing to note here is if your patient has hypertriglyceridemia, this actually increases VLDL production. So because of that, it actually can increase your triglycerides. So if you had a patient who, say, had a familial hypertriglyceridemia, you want to give this to, this would worsen that, okay? So one notable thing here is that this will have maybe minimal effects, but for some people it's going to increase their triglycerides. That's the first time we're really seeing that, okay? And again, the resins here, so one thing you may actually find is that they can bind up with calcium as well. So that can be problematic if your patients are, say, on calcium supplements for osteoporosis or things like that. So one thing you want to note. Okay, so as I mentioned, they bind to a ton of different drugs here. So just an example, a lot of these we're going to talk about as we get into like cardio part 2. Coming up a little bit later on, but they'll bind up to a ton of medications. So as I mentioned, either administer the other drugs an hour before the resin or 4 hours afterwards. And just goes to show you how long they kind of stick around for. You have to separate out that much.
Quick question for the folic acid. Would you worry about that in pregnant women too?
Mm-hmm.
Okay.
So I could, and so you'd be thinking about it from like a dietary standpoint, right? So their folic acid, we have a lot of folic acid fortified in our foods anyway, right? But also think about they're going to be taking a multivitamin, hopefully prenatal, so they can then take that hopefully beforehand, maybe with their other medications that would get around some of that.
Okay.
This is just talking about like just from the dietary intake how they could interact with the niacin, or not the niacin, the folic acid seen there. Right? Get my B vitamins all mixed up, as you can see. Yep, so that's an important factor. Just make sure they're separating it outright, which can be problematic because, again, timing of medications can be important. If you're you have a busy on-the-go schedule, you may not have 4 hours to sit around and wait for your meds to, or they may forget to take them, or things like that can happen for sure. So other contraindications, as I mentioned, if they have familial increased triglycerides or if their resting levels are already above 400, this is just going to worsen that, so I would not recommend that. And then just as a relative contraindication, if it's above 200, again, the risk for worsening is there, so I would just avoid it in those patients too. So where are these going to be useful? Again, they're the safest overall because they're not going to have any risk of systemic effects because they don't get absorbed systemically. However, because they're so poorly tolerated, they're going to be used pretty infrequently. Like I said, pregnant patients, maybe kids might be the one place you might see these being used. But that's probably the biggest places there. And again, overall, efficacy is going to be kind of minimal, especially compared to something like a statin anyway. So their LDL effects are kind of moderate at best. All right, next is going to be niacin. This is actually a B-complex vitamin. Nicotinic acid is another name for it. You may find a different form called niacinamide as well that can be used. Now, all the agents we've already talked about have been prescription-only agents here, but niacin itself is just a B vitamin, right? So can you find this over the counter? Where do you find it at? I guess not the store specific. Which part of the store might you find it in? You're to scour it. Usually the dietary supplements, right? Vitamins, dietary supplements, and other things like that. You're going to find that we do have a prescription-based product that is going to be usually a little bit more potent. Again, what's the problem with dietary supplements? It's not quite as much regulation in terms of the FDA making sure that the products are all super consistent and saying that they say, hey, this has 100 milligrams of niacin. Well, no one's really double-checking them to make sure, right? You're just kind of going off of the company's own word at that point. So there is some a little bit less confidence that every product is going to be made the same. So if you're like buying out of the back of some guy's truck, like maybe don't trust that person. I don't know, but I wouldn't buy my drugs out of people's trucks anyway. Unless they're coming from like the Amazon truck or something, I'd say, bring it to me. I'll take it all. So anyway, so niacinamide, though, if you ever see this form of it, this is actually not going to be effective as an anti-lipemic. Some people may take this thinking that's the case, but this is not going to be all that effective for them. Typically, the prescription-based products are going to be a little bit stronger in terms of their effects than what you might see in like a dietary supplement form. So there's a few different formulations you're going to find here. So for instance, we have like an immediate release one. You can find niacin as a supplement, as I mentioned, or you can have like Niacor, which would be like a prescription-based product. There's going to be some problems with the immediate release, and most people will shy away from these. And I'll share a humorous anecdote with you in a few moments to illustrate that. I hope it's humorous at least. Long-acting is going to be used much more frequently, and it'll usually say like long-acting form or slow release or something like that, niacin. And then we have an extended-release formulation called Niaspan, and this is going to be another prescription-based one. All right, so this is normally what you would end up getting from your pharmacist or from your provider. There's another form you might find as a dietary supplement called inositol hexaniacinate, and that is going to be another dietary supplement you may find occasionally. Okay. So, yes, sir.
What's interesting, long-acting extended release?
Basically, the release characteristics of it is probably not a ton in terms of like your purposes for remembering it. Just know that long-acting forms are going to have some benefits in terms of the side effects. We'll mention those in just a few moments here, right? So anyway, some of the things that this is going to be doing for us is, one, this is going to help to kind of limit the liberation of free fatty acids from things like adipose tissue. Normally, we bring fatty acids into the liver, like we'll uptake it from there to help with the synthesis of triglycerides. By inhibiting this process here, what does it do to your triglyceride count? It's going to go down because you can't make as many VLDLs, and that's going to have some downstream effect on LDL. And then also what you end up seeing is kind of another ancillary benefit of this is that it's going to increase your HDL. So big thing here is you're preventing the liberation of free fatty acids. It's going to cause lowering of your triglycerides, increases in your HDL, and some moderate effects on LDL. What other category kind of did similar effects? Yeah, your fibrates. Yeah, fibrates kind of have a very similar pattern of lipid effects as you're going to see with your niacin. So just kind of keep that in your mind here. But again, as we're going to see decreased mobilization, it means you're going to have less triglycerides being formed here from the fatty acids in the liver itself, and that's going to cause more of these less VLDL to be released here out in the bloodstream, which causes less LDL to be formed overall. Okay. So the immediate release formulation, you can see here how it's going to be dosed, very frequent, BID, TID versus, the extended release is nice because you're only doing it one time a day. The other downside of the immediate release, though, is that oftentimes will cause more kind of immediate sort of side effects here, which we'll mention in just a moment. The extended release is nice because it has a slow release characteristic throughout the day, so you're not going to see such pronounced sort of effects here. The big thing you're going to find is this cutaneous flushing that you get with this. Basically, niacin helps to stimulate production of prostaglandins. We've talked about prostaglandins previously, right? In terms of like cyclooxygenase and NSAIDs and all of that. You end up seeing a lot of flushing associated with this. It causes a lot of vasodilation. And so this can actually be minimized by pre-medicating with aspirin. So sometimes they'll say if you want to take immediate release, take an aspirin beforehand, like a 325 milligram aspirin, and that will help to prevent a lot of that. Why does that make sense? Yeah, aspirin's going to block cyclooxygenase. This is not going to make prostaglandins that the niacin would then stimulate, right? Again, you're going to see some nausea, some abdominal discomfort, and then with larger doses, you can see some effects on things like glucose. You can see some effects on uric acid, and you may actually end up seeing some decreased glucose tolerance, which might be problematic for which kind of patients? Diabetic patients, they probably already have a degree of glucose intolerance to begin with anyway. So, as I mentioned, extended release, you're much less likely to see those cutaneous effects. Some of the GI effects are being mitigated. Immediate release, though, you're going to see quite a bit of that. So let me tell you my funny story. So there was a time when I was on rotations, and I was working at a family practice clinic. It was like they had a family medicine residency there. This is actually at UF. And so they had a couple of different clinics throughout town. And so I was on a rotation with a fellow classmate. They were at a different clinic than the one I was at. So we'd often carpool in I drop them off at their rotation site, and then I would go drive to mine, and then I would pick them back up at the end of the day, right? So anyway, so they had a couple of pharmacy students that were at their rotation site, and they said, well, we should do like a niacin challenge. We should see what our patients have to go through and just take a bunch of immediate release niacin and see what it's like. It was a slow clinic they were working in. So I go to pick up my classmate, and they get into the car, and they are completely red from head to toe. I mean, like, they look like a strawberry practically. They're so red. They had been actively vomiting like 2 seconds before I picked them up. They felt so miserable. Headache, pounding headache, sweating, red hot. I was like, what happened? How much niacin did you take? And they said, too much. So they ended up drinking like a gallon of water over the rest of the night, went to bed early, and felt okay the next day, but needless to say, they did not pre-medicate with aspirin beforehand, and they got the niacin flush. Now, hopefully your patients will not take that much, see that, and you can recommend if they do have any issues with it, take the extended release, and it should help to mitigate that, right? So again, very common with niacin to think about that in terms of the flushing reaction you can see there, okay? Anywho, again, patients who should not receive this, chronic liver disease, you can see some exacerbation of this. And then in terms of relative effects, be careful they have diabetes, they have a history of gout. These are things you want to think about in terms of those patients there. This can sometimes worsen peptic ulcer disease. Again, just kind of exacerbated by the GI effects you're going to see with that. So those are the big things to worry about in niacin. In terms of niacin interactions, kind of mentioned some of these already, where you can see things like statins, kind of increasing levels of the statins there, worsening some of the hepatic effects. ETOH, what do you think? What kind of interaction do you think you can see with this? So remember we talked about the flushing reaction you get with like metronidazole plus alcohol. That's due to that product called acetaldehyde that builds up. So having niacin on board actually exacerbates that acetaldehyde kind of flushing reaction there. So something you want to recommend avoiding taking together if you can, or at least pre-treat with aspirin if you really needed to do that. However, what could be a risk if you're drinking alcohol with aspirin? What does alcohol do to your ability to clot? Decrease it, yeah. It's actually kind of a natural sort of anticoagulant in itself, so you can see increased bleeding risk. So again, don't do a bunch of aspirin and alcohol. Not a good idea. I have some patients like that. They don't do well, as it turns out. Anywho, so we're going to see niacin in place. Again, this is going to be useful for patients who have relatively low HDLs, if they have high triglycerides, similar to the fibrates. Usually not going to be first-line therapy, but it could be a decent add-on if you need to do so. Okay. Here you can even see some cases where I combine a statin plus niacin to get some additional synergistic effects here. So for instance, we have like Advocor, which is lovastatin plus niacin. Mixing them together here can have some additional benefits. So you can have like a 50% reduction in LDL, some pretty good effects here. But again, looking at the triglyceride decreases and HDL increases, fairly beneficial effects from that standpoint. Okay. But again, all these effects are going to be worsened by combining two together in terms of hepatotoxicity and myopathy being a risk. Okay. So next we have this newest class of medications here. These are called the PCSK9 inhibitors. So this is like brand new, hot off the market kind of thing here. On the market, I should say. They're off the presses, but on the market. Whatever the analogy I'm going for there. But these are monoclonal antibodies. And how can you tell that? They have MAB at the end of the name. So you have alirocumab and then evolocumab. And again, these are on the easier side of MABs to actually say the name of, right? When we get to the cancer section, you're going to see some really nasty ones like, I'm trying to think, can't think of any that are coming to mind right now, but you have like tocilizumab, and you have things like, infliximab's pretty easy, but there's a lot of weird ones. Anywho, these two here are going to be very kind of interesting in terms of their mechanism. So there's a certain protein that your hepatocytes make called PCSK9, and essentially these are responsible for processing a lot of those LDL receptors in the hepatocytes. Normally what you find is that PCSK9 is responsible for helping to sort of cause that recycling of the LDL receptors. So overall they have sort of a diminishing sort of effect on the number of receptors at the surface. So what I can do here is I can use these, and what dosage form is it going to come in? An injection, right? Why can't I give it orally? GI tract is just going to tear it up, right? Just like any other protein would. So GI tract is not going to be a good route for this. So I can give this subcutaneously. Patients can administer it themselves. You can see here, it comes as like a pen sort of formulation. They'll have little pen needles they can put on the end and then dial in their dose essentially. And so you'll find that this will basically, by having an antibody that comes and binds up that PCSK9 in the hepatocyte, it prevents that from causing that recycling of the LDL receptors. So what does that do to the LDL receptor count at the cell surface? They never get recycled away. They just stay there until they bind up some LDL, and then they get recycled at that point. So what this does is cause really dramatic decreases in your LDL concentration. What's kind of interesting in some of the clinical trials they were running, they actually found some patients whose LDLs were undetectable. They had such a good effect from these drugs there, and they're like, well, what's the clinical relevance of having no LDL in your blood? And they're like, we don't know. We just couldn't detect it in these patients anymore, so hopefully it's nothing bad. We don't know. However, what do you think about the cost of these drugs? Very expensive, right? You can get simvastatin for pennies for a pill. This is going to be in the course of like several $1,000s for treatment. So very, very expensive because it is difficult to engineer these antibodies, or it's an expensive process, right? And again, what's the biggest side effects you're going to see with these, or a concerning side effect you think about? Yeah, allergic reactions to these. Why is that? These are foreign proteins, right? Your body does not recognize these proteins, and it could either work. Best case scenario, could produce antibodies that will neutralize them, where the drug doesn't work anymore, or worst case scenario, can actually bind them up or cause an anaphylactic reaction to actually occur there. Okay. So those are new ones. Here's kind of an old table that does not include the PCSK9 inhibitors, but they're kind of good to show you sort of general effects on cholesterol, different facets of the cholesterol panel here with the different classes. Again, statins are generally going to be first line for the majority of patients here. Good effects on LDL, pretty decent effects on triglycerides, okay effects on HDL. The big ones are going to be most beneficial for HDL or what? Yeah, so nicotinic acid and your fibrates. Okay, those are going to be the biggest effects here. Which one's going to be the worst for your triglycerides? The resins, right? Resins might actually increase it in some cases. You got to be really careful with that. Which ones are best for triglycerides? Fibrates and nicotinic acid, right? So those are kind of trends I want you to kind of notice there. So if I had a test question, is that a patient presents with this lipid panel, and I'll give you the reference ranges, but they come out and their triglycerides are really high and HDLs are really high, or really low, I should say, then you'd be able to pick out, okay, well, I know fibrate would be a good option here, or I know nicotinic acid would be a good option for these patients here, okay? Just kind of things I want you to kind of notice. So actually measuring your lipid panel, I'm sure you've covered this in other classes, maybe Clean Lab or something like that. But when you look at total cholesterol, it's basically just trying to add up your HDL, VLDL, and LDL together. However, when you actually measure it, you get a triglyceride count and not an actual LDL, or VLDL, I should say. And so what they'll actually do is use a little conversion here. So you can actually take your triglyceride count, divide that by 5, and that's how you end up calculating that. So just note, I'm not going to quiz you on this specifically, but in case you're ever curious, that's where you get that from. Now, our old goals that we used to have for treating hyperlipidemia, and hopefully this will jive with what Dr. O has been saying, because you've covered this yet with Dr. O. Fantastic. You'll let me know if I'm wrong, right? Hopefully. I encourage that, right? If I'm wrong on something, you point it out. Anywho, so the old goals, we used to have like the ATP3 guidelines, and they would say, okay, we want to make sure we're getting to certain numbers, right? So we want to make sure we go ahead and get the LDL down to below 100. We want to get the HDL, above 60, total cholesterol, those certain goals. Because of that, we're starting to move away from that now, and more focusing on what is their like cardiovascular risk, right? What is the risk for developing things like heart attack or stroke going on in the future? And so you're starting to see this is where the new guidelines are reaching towards, right? So again, we're going to be not focusing on certain numbers to reach, but shooting for certain intensities of drug therapy, right? So how high can we drive our statin doses, right, before we start to see toxicity? And based on the disease states the patient has, and based on the risk they have for cardiovascular disease, you'll see that we can shoot for different targets. So anyway, as I mentioned, you're going to find that patients fall into several different categories based on their cardiovascular risk. We're going to see that instead of looking for a specific LDL goal, we're going to be shooting to either getting them on moderate or high intensity statins. And a lot of how high you can drive that dose is going to be tolerant or dependent on how well your patient can tolerate that. And then we're going to go ahead and measure lipids anyway after follow-up, because we want to see, well, one, are they being compliant, right? Because there's not many people you can put on 40 milligrams of rosuvastatin and not see their LDL go down. So if it's staying the same, they're probably not taking it. And then you can also assess some other things as well, like how their HDL is doing, triglycerides, etc. So looking at the 4 major groups of people that they have noticed statin benefits with, okay? It's going to be people with a clinical history of atherosclerotic cardiovascular disease. So if you've had a previous heart attack, you're going to get big benefits from the statins, right? And again, this is why you end up seeing people with a history of a heart attack, CHF, things like that. They're going to have like a huge long med list, and it's because of these benefits. We know the guidelines say they need to be on these group of drugs here. This is one of them, right? Anyway, if their LDL is above 190, they get big benefits from the statins. If they have diabetes mellitus, if they are, say, between 40 and 75 with an LDL of, say, 70 to 189, and without a history of cardiovascular disease, these are patients who may benefit. And why do we care about these patients with diabetes? We just know they're going to be a big risk for cardiovascular disease going forward because that's their disease state. We'll talk much more about that in the endocrinology section a little bit later on. And then if they have, people who have, without the history of ASCVD or diabetes, but they do have LDL that's in the 70 to 189 range, and they have this estimated 10-year risk greater than 7.5%, they are also going to be at risk for cardiovascular disease that is enough such that they will benefit from statins. So these are actually from the 2018 updates believe the old ones were right from 2015. We got to these new recommendations. These ones from 2018. And so again, when you're taking a patient, you kind of just work them through the algorithm, right? You kind of see what's their age, what are their disease states, and then it will kind of give you an idea of just how much at risk they are. And then based on that risk, it'll tell you, okay, well, what do they need to be on? Do they just need to be on moderate intensity statins? Is it dietary intervention alone, exercise, diet, or do they need to be on high intensity statins? These are things you're going to be looking for, right? So anyway, so again, imagine if you have a patient who's, say, for instance, say 40 to 75, right? Going through here and then looking at their, okay, let's look at their risk pattern, right? And we'll look at a calculator here in just a second to look at some of the things they're going to be looking at there. But looking at, say, someone who's at, say, for instance, intermediate risk. Looking at this, you're going to see, okay, well, let's see if they have anything that helps to favor to use statins. And it'll introduce moderate intensity statins to reduce their LDL by 30 to 49%, right? So basically working through the algorithm to say, okay, well, what do they need here? They need moderate, or do they need high intensity statins? And again, I'll show you another graph that'll make a little bit more sense of that in a moment here. Anyway, and so here looking at these patients, obviously the first thing you always recommend, healthy lifestyle, but does everyone always stick with that? Was always successful? No, because hard things are hard, right? But here looking at their high-risk ASCVD, we can see here they want high-intensity or maximal statin, right? So basically you're going to shoot for really high doses of some of these statins and then back off depending on how they develop side effects and things like that. And then again, based on the monitoring, you can see like, well, do I need to add something on board? So for instance here, if a PCSK9 inhibitor is considered, maybe adding Ezetimibe to maximal statin before adding one of these. Again, a lot of these things, we know that statins are really good, but after that, we're not really sure what's going to be the best things to add to those patients there. Now, what do you think might be a benefit of using, say, Ezetimibe over a PCSK9 inhibitor for some of these patients? Way cheaper, right? Extremely way more cheaper than, that's not very good. English not good today when talking for 2 hours, but it is going to be much cheaper than using something like a monoclonal antibody to manage that. So that's something you want to keep in mind here. But again, this is where you add on additional drugs if the statin by itself is not good enough to get kind of those LDL lowering levels you're looking for. Anyway, but again, looking at other things. So if you look at their ASCVD risk is not very high, then you kind of look at their age and determine, okay, well, do they need moderate, high-intensity statins here? Now, let me show you, this is a table that kind of shows you how you calculate that risk. So what is their 10-year risk based off some of these different factors here? So again, we mentioned if it's more than 7.5%, they're kind of considered high risk there. So you say if you're male or female, which one do you think puts you at bigger risk? Being a male, it just turns out, yep. That Y chromosome, even though it's so awesome, it puts us at risk for certain things, heart disease. Obviously, your age, ethnicity, cholesterol, blood pressure, all that kind of stuff, right? It'll spit out a number at the end there. I'm not going to belabor those points, but again, online calculators are wonderful. Pop you out a number, and it'll again tell you what the risk is over the 10-year period. So this is the table I want to get at here when you're trying to determine, okay, what's going to be good in terms of high intensity, low intensity statins here. And so this is what we're looking at. When we say high intensity, it means we're hoping to get more than a 50% decrease in your LDL. More moderate intensity, we're hoping maybe 30 to 49, and lower intensity, say less than 30%. Now, what I want you to notice here is that not every statin is built equally. So these are good things to know here. Are going to be what are your most potent statins that we have? What are the things that are going to get us the most bang for our buck? And that's two of them right here. It's going to be rosuvastatin, which is Crestor, and then atorvastatin, which is Lipitor. Those are your two most potent statins. Anyone mention which one's more potent than the other here? Why do you think atorvastatin is more potent?
I see it all the time.
See it all the time. You use less of rosuvastatin to get the same effect. So that one is actually more potent, right? Right? Pharmacodynamics coming back, right? Anywho, why do you see a lot of atorvastatin though? It's older, it's cheaper, right? Crestor is still a little more expensive, right? So again, these are things you have to consider, right? What does the patient's insurance cover? Where can they get this stuff from? How much is it going to cost them? Because if something's too expensive, they're never going to take it, right? So you could use either one of these. And notice here that rosuvastatin is roughly twice as potent as something like atorvastatin is. So you can either do rosuvastatin 20, atorvastatin 40. Again, I'm not going to ask you specifically the dose you're shooting for, but you should know that if I say a patient, if I give you a patient case and say they have diabetes and they're 90 and they've had a heart attack and what kind of drug should they go on, and I show you something like lovastatin, you're like, that's never going to get kind of LDL decreases I'm looking for. Fluvastatin, get out of here. That stuff's weak, right? You're going to say either atorvastatin or rosuvastatin, right? Those are your two money makers in terms of getting the LDL down under control, right? And again, the point is not necessarily to get that percent reduction down, but it's again to get the highest dose you can, the patient can tolerate in order to make sure that they are getting those extra pleiotropic effects of the statins.
Dr. Oakman suggested that those two were reported because there's no studies on them.
Okay.
Is that kind of contributing to it?
That can contribute to it. So again, you may find some of it could be related to like how many studies are done, depending on drug companies maybe funding some of those. Who can say, right? We talked about, actually, does anyone watch their EpiBio from the other day? We talked about publication bias a little bit and how people only like to publish positive results, right? So that's kind of a problem in medical literature. For some of you, this is a preview for the EpiBio lecture you get to watch. Maybe over the weekend on Friday night when you got nothing else to do because you're a PA student. But also, these do happen to be the most potent out of the bunch there, right? So if you just look at the comparative doses between the two, rosuvastatin tends to be kind of on milligram per milligram, the most potent out of the bunch, atorvastatin as a secondary to that, right? Because again, you could try to shoot for something like, 40 milligrams of simvastatin, right? And actually, to get an equivalent dose to one of these, you'd have to use 80 milligrams of simvastatin, but usually by that point you're driving the doses so high, the toxicities are normally what you're going to be running into at that point. That's going to be your major roadblock. These two, though, tend to be the kind of the best bang for your buck, and that's what the guidelines recommend. Okay. Now, what happens if I started, say, a patient on 20 milligrams of rosuvastatin, and I see their LFTs are starting to bump a little bit, and they're complaining of muscle aches? What could I do? Take them off of it completely? Try to lower the dose first, right? Because again, this is going to be our gold standard. We want them on a statin. We may just need to decrease it. Right? Maybe decrease it to where they can tolerate. What's the, and again, going back to that table we're looking at in terms of the comparisons between the different statins there, what's the other big benefit of rosuvastatin over atorvastatin from a kinetic standpoint? No. It has to do with the metabolism. Rosuvastatin does not have any CYP interactions. Atorvastatin is metabolized by CYP3A4. Okay, that is another important point to note there. So again, if you want to minimize the drug interactions because they're on a bunch of other cardiac meds that will inhibit CYP3A4, rosuvastatin is a better option. Okay, so these are important things to consider there because when they go and they're in the hospital for an MI and they get put on all these different medications, you got to make sure there's nothing that's going to really interact and cause some problems there. Okay. So anyway, in terms of the statin recommendations, make sure you're selecting the appropriate dose based on the guidelines and kind of see how they're doing with it, after a period of time. We're going to be bringing them back to monitor their LFTs anyway, so you can monitor for that. Again, if it's not tolerated, go down to the maximum tolerated dose. That's going to be better than nothing in most cases there. Any questions on that section? Let me look at the board real quick. Any other questions here? Why is it recommended to start with a high-dose statin initially? If the higher the dose, the higher the potential for side effects. Does the benefit outweigh the risk using a high dose? Most other drugs, it's best to start out low and bump up the dose if needed. That's very true. Most drugs, a start low and go slow sort of mentality is generally good. However, what we see, at least in the studies that have been done, is that the higher the intensity you start them out with, the better off their effects in terms of long-term mortality. So that's kind of the thing you'll see, like depending on what you're really into. So if you're into cardiology, there's all kinds of studies that are out there that include thousands of patients. They followed them for 10 years. You guys ever heard of the Framingham heart study? Yeah, they've been following those patients for decades, and it's well, that's the best strength of data you can hope for. But you look for toxicology articles, and I can't poison patients on purpose to get some good data. And it's what the heck, But it goes to show you, depending on kind of where you're at, you may find that those recommendations are coming from really large, well-designed studies, and that's where we can say things like that, where we can say, yeah, we get the benefit. We've been following them for 10, 20 years. We can say that we know they're going to be less likely to die based off of the fact that we watch them die, essentially, right? So that's why we want to say go with those big doses, and then you can go down from there. This is one of those cases that most other times you're going to say, yeah, start low, go slow is going to be the general mantra. So it's kind of where a lot of that comes from. Any other questions? If not, I'll see you guys next time.